said, my name is Chris Thompson. I've been here in the burn center about 25 years. A lot of my responsibility is charge nursing, but I also do quite a bit of education as well out in the public, pre-hospital and hospital settings. A lot of misconceptions out there about burn care, so I'll see if I can clear up a lot of that today. So without further ado, let's just jump right in. I've got Kyber keep with me real quick. I can let her do a quick introduction before we get started.
Good morning. My name is Kyber. I also work in the burn center here in Kansas with Chris. I've been here for about 10 years. And we're going to go through and get the slideshow going for you. There we go.
All right. So just real quickly before we get started, we just wanted to talk about patient confidentiality. I can tell you that every picture I will show you today, we've had some kind of consent, whether it's from the patient, the family member, but they did know that we were using it for education. So kind of what we're going to talk about today, we're going to kind of talk about general burn terminology. We're going to talk about special considerations besides your thermal burns. We'll talk about chemical and electrical burns as well. We'll kind of dive into the pediatric burns. We'll talk about TBSA, calculating out total body surface areas. There's a lot of pitfalls in burn. This tends to be one of the big ones. How big of a burn are we actually dealing with? And that has to do a lot with how much fluid resuscitation we're going to give them. And that's the second big pitfall is we tend to get patients way over fluid as opposed to under resuscitated. So we'll talk about kind of our protocols, kind of our recommendations out there in the world or in our state as far as how much fluid do we actually give these patients? Because as we know, giving them too much fluid can be detrimental. Giving them too little fluid can be detrimental as well. So we will kind of talk about that. And then we'll kind of go into like the ABCs of burn care. So just real quickly, your basic definition of burns is damage to the skin and underlying tissue. That is your baseline. And this could be caused by a number of different things. The ones we tend to see the most are your thermal burns, that being your fire, your flame, scald, contact, someone grabbing something hot and so forth, and then radiation. We also have chemical burns. We see those very infrequently, but we do see them. We kind of break down chemical burns in two different categories, your acids and your alkalis. We also have a third portion of chemical burns, which are your organics. This is your petroleum type products, your gasolines and so forth. And then on top of that, we have electrical. And when we get to electrical, we'll show you why electrical can be just as damaging to the patient. So jumping right in, what does our skin do for us? Well, it protects us from injury. It also keeps all of our fluids in, sensation and appearance. But our biggest one that we deal with is temperature regulation. If we have a 50% burn and we lose 50% of our regulation, we're going to go hypothermic. And we see many patients come in that are hypothermic. And when I go out and I teach and I talk, I always tell them they really, if you do nothing else, if you can keep your patient warm, if you can keep that core temperature up, your world's going to be a lot better off. Treatment's going to be better off. It's one thing to deal with a burn patient, but you throw hypothermia on it, you throw it into a whole different ball game. So that temperature regulation right off the bat is going to be the big thing that we're going to deal with. Body fluid loss, 24 to 48 hours, they will continue to seep out. So we have time to deal with that. And that's when fluid resuscitation comes into play. But like I said, if I can stress over and over again, we got to keep that temperature up. And whether it's the middle of the summer or dead of winter, that patient will go cold on you really quick. So the big question people always ask is how deep of a burn it is. And what I mean by that is they always want to know, is this the first, second, or third degree burn? Now, we've in the past couple of years have kind of gone away from that terminology. We go more of the superficial, partial thickness, and full thickness burns. So if I flip flop back and forth, just remember if I'm talking about superficial burns, I'm talking about first degree burns. If I'm talking about partial thickness, I'm talking about second degree burns. And then your full thickness being your third degree burns. So, what are some of the things that influence how deep it is? Well, once again, how hot was it? If it was a scald burn, was it just water? Was there oil in the water that made it hotter, or so forth? Your length of exposure, and then your dermal thickness. Now, some of us may take a little longer time to burn than other people, like myself. But the other thing I have going against me as the older you get, the thinner your skin gets. So the very young and the very old are going to burn a lot deeper, a lot quicker than most of the people will do. And the other thing that determines depth is your mechanism of injury. Chemical burns come off a whole different appearance than your thermal or your electrical type injuries. So what type of injury, what caused that initial burn insult? So if we all think back, we look at the structure of the skin, your epidermis being your outer layer, your dermis, your middle layer, and then your subcutaneous fat and bone and muscle and so forth, or your third layer. If you look at your burns, your first degree or your superficial burns will not break that barrier of skin. Basically, it's a red burn, sunburn we're looking at. It will blanch. You can push on it. It will go back to color, then come back to that reddish color. The big thing with burns is there's really no magic potion out there that we prescribe to help sunburns. We can tell people aloe vera works sometimes, but once again, it's just going to be a discomfort to them. The problem that we run into is once we get past that epidermis, we get into the dermis, we start exposing nerve endings to air. And it's not necessarily the burn that's hurting these patients, it's more the air hitting the nerve endings. A lot of times, if you can cover that burn up, you can take away a lot of the pain. But once again, you have other factors that are going to be come into play once you get the burn. So, first layer epidermis, your middle layer dermis. Then once you burn below the dermis, you get to the third degree burns. You basically destroyed everything. These are the burns that they won't feel. They'll say they feel some pressure. But once again, the pain portion of it will be taken out of play because you destroyed all that structure in there. We actually have a fourth degree burn that goes down to the bone. It chars the bone. But nowadays, we just lump it into the full thickness category. So once again, superficial, partial thickness. But in partial thickness, you can have a deeper partial thickness. And it all boils down to physician observation on what they're going to call the burn. So your superficial burns, we talked about red, it will blanch, sunburn. Just think of a sunburn as your first degree burns. You're not going to get a lot of blistering on first degree burns. Every once in a while, we'll get the fair skinned person that will get these little water blisters. We don't really truly count those as blisters so much. So why is that important? Because we never calculate in first degree burns or superficial burns into our calculations. And when I say we tend to get a lot of patients that are overestimated, a lot of times they're calculating in these first degree burns with it. And if we have this picture, as the picture shows, if you remember your rules of 9, backs 18, there's a big difference between how we would treat an 18% burn as opposed to how we would treat a 0% burn. So, like I said, the big thing just to keep in mind with your superficial burns is you never put that into your calculations. Your partial thickness burns, this is where we start to get blister formations, whether it's blisters, whether it's loose skin or so forth. The distinguishing factor between this is that area will still blanch. So you can push on it, it will blanch, it will do kind of like a first degree burn, but once we see the blisters or the loose skin, we're usually dealing with second degree burns or partial thickness burns. Once again, with the partial thickness, these are non-surgical type burns. They will heal on their own about 7 to 21 days. But these are truly the most painful burns that people are feeling. Like I said, a lot of our dressings and so are geared towards covering the burns up. I always tell people from a pre-hospital standpoint, if you want a good burn dressing to carry, it doesn't have to be sterile burn dressings. Go out and get the biggest box of saran wrap you can find. Saran wrap does everything you need it to do. It covers the burn up, hence keeping the temperature in. It won't stick to the patient. And you can kind of see through it and see exactly what you're dealing with. So a lot of our EMS have implemented that over the years, carrying saran wrap on. Besides saran wrap, we tend to use a lot of petroleum-based products on our second degree burns. We also debride blisters. I know that's always a big thing out there is, do we pop blisters? Do we leave them intact? We remove all blisters just because that skin's going to, at some point, you're going to lose it anyways. So if we can uh, de- decrease the healing time, more functionality, especially with the finger burns, we'll remove them. But once we remove them, we know at that point we're instilling more pain to the patient. So we get it covered up, whether it's a petroleum gauze dressing such as Zeroform or Adaptic. We use a lot of bacitracin with our burns, and so forth. So basically, a once a day non-adherent type dressing. Like I said, these burns will heal on their own, but it's going to take a little longer. No surgical interventions are needed with these. Some examples of partial thickness or second degree burns. If you can look at the picture on your left, you can see intact blisters and loose skin at that point. Same way with the child on your right. That's classic skull pattern that we see. Pulling it down from height, goes across the chin, across the chest, and so forth. All that skin at some point will be debrided in the back, and we will place dressing on it, whether, like I said, Zeroform and bacitracin or so forth. Once we get it up, we decrease the pain. The problem that we run into with burn patients is not only are you dealing with pain, you're also dealing with increased anxiety. So if you treat one, you've got to treat the other, because if you don't treat the other, it will override. So kind of co-pharmaceutical type effects, whether it's Dilaudid and Versed, Ativan, we always give one and we always treat both at the same time. Um, your third degree burns or your full thickness burns, like I said, these are the burns that basically destroy everything. They're going to feel a pressure type to the area if you go to push on it and blanch, but they're not going to complain of that increased pain like you would see on a partial thickness burn. Um, People always think of full thickness burns as that leathery tan appearance. Third degree burns kind of will show their face different areas. You can get that waxy look, you can get that whitish pearl area. I always tell people the best way to tell if it's a full thickness burn is get your hands on it and feel it, because once you feel a full thickness burn, you won't forget that. Very tight, very non-elastic. You've lost that elastic mobility. So get your hands on it, feel it. Like I said, with chemicals, you can get a beefy red area. I think I've got some examples. If you look at this gentleman down in the picture, you got that charred look. If we were in the old days, I would say that was probably fourth degree burns to the lower legs. But as at this point, we'll throw it into full thickness category. That's going to be non-blanchable. That's going to be non-elastic. It's going to basically create a band around that area, especially if it's circumferential. And we'll talk about that here in a minute. If you look at the picture to the right, when I talked about that pearly white look that's on the hand right there, if you would put your hands out, you could feel that it's lost all elasticity at this point. Like I said, you could push on it all you want. It's not going to blanch. You don't have good blood flow to the area and so forth. And when we start talking about circumferential burns and full thickness burns, the problem that we run into is, like I said, you lost that elasticity. Your body's going to swell because of the amount of fluid we're giving, and something's going to have to be compromised. And a lot of time it's the circulatory system that gets compromised. On extremities, on chest walls, you tend to get that chest wall rigidity and so forth. So what comes into play at this point is we're going to have to do something to get back that elasticity. We're going to have to cut through that eschar. We're going to have to relieve that. And what they do is a bedside procedure is called an escharotomy. And whether they do it with a scalpel, they do it with a cautery iron. Basically, it's a cut from good skin to good skin if you can do it, medial and lateral to the area. That will open it up. That will allow circulation to get back to the area. If it's on the chest wall, if you're having to bag them and you can't bag them, you're not getting good tidal volumes. We've done escharotomies on just about every part of the body. So one thing to keep in mind, if you do have a big burn, and especially if it's circumferential around the chest, is at some point that's gonna hamper the respiratory system. So we're gonna have to do something about that. As far as calculations, when I talked about it earlier, we've all learned the rules of 9. Just keep in mind the pediatric population is a little more compact. You get a little more for the head and the trunk. The extremities are a little shorter, so not as much as the adult right here. But just remember, if we're going to give it 18% on the back, it's got to be a full back. If it's a full arm, it's going to be 9 and so forth. It's just people kind of get close and they'll overestimate it and so forth. They will throw first degree burns into it. So, like I said, when we talk about fluid resuscitation, not a lot of what's done first hospital, pre-hospital, and so forth are based off of a calculation, as we'll talk about, but it's nice to be in the ballpark. As far as physicians, I can say the majority of the physicians use this London Browder chart. This breaks it down a lot more specific as far as hands, arms. Instead of doing 9 for the arm, it breaks down to the upper arm, lower arm, hand, and so forth. If it's a smaller burn, you'll see a lot of us use this Palmer method. It's the palm of the patient's hand. The size of the patient's hand is approximately 1% of the body. So if our hands are close to theirs, we can kind of go over a scattered burn and kind of give a guesstimation on how big that burn is. But once again, if you're the first hospital, or if you're pre-hospital or so forth, a lot of what's being done shouldn't be based off of a calculation. As far as specialty populations, like I said, we have, besides our thermal that a lot of us are used to dealing with, we also have chemical, electrical, and type injuries. When we talk about chemical, usually not thermal in nature. It's basically it's more noxious substance to the skin around it, so it's burning from the inside out. Once we break it down, acids versus alkalines, it's a totally different type of injury between the two. But once again, the treatment's going to be the same. And with any chemical injury, it's basically dilute it. You've got to get that pH back to 7 to neutral. So when we talked about hypothermia and so forth, this is the one time that we're not going to worry about hypothermia right off the bat, because we're going to be diluting this chemical over and over. So if it takes 30, 40 minutes, that's the time that we're going to spend to get the chemical back to neutral. Different types of injuries, you can absorb chemicals, inhalation, and ingestion. Majority of the chemical injuries we see are absorption, although we will occasionally get the ingestions, whether it's intentional or unintentional type ingestion. Like I said, when we break it down, your acids are more coagulated necrosis, your alkalis are more liquefaction. So basically, you either have a drier chemical burn look or a more wet, soupy type appearance. And that's kind of how you can distinguish between the two if you don't know what the chemical is right off the bat, if you don't have the MSDS sheets or so forth. If it looks dry, it's probably going to be more acidic type burn. If it's more wet, soupy looking, it's going to be more your alkalis. Your organics, your gasoline types basically will destroy. So we talked about the pH on your alkalis. Once again, on the acids, it's less than 7. On your alkalis, it's greater than 7. More on your alkalis, you kind of find them more in like the oven and drain cleaners. We get fertilizers and so forth. Your acids, we tend to get more industrial, your hydrofluoric acids and so forth. We never try to neutralize chemicals. The only chemical that we will ever attempt to neutralize, if it's not done prior to them getting to us, is hydrofluoric acid. And basically that binds with calcium. So it's a calcium gluconate type topical that we will put over it. We'll try to break that bind at that point. We'll keep applying it till the stinging sensation uh, starts going away. Once that starts going away, then we revert it back to regular burn care at that point. But once again, on any chemical, we never try to neutralize it. Like I said, a lot of times you will get an exothermic type reaction. It will be as heat involved. So not only now will you have the chemical burn, but you'll have the thermal burn on top of that as well. Like I talked about just a little while ago, basically our job when the chemical burn comes in is we got to get it neutralized, whether we use pH strips and we use the runoff water off the burn to tell what our pH is at that point. It's going to be irrigate, whether it's on the skin itself, the eyes, or so forth. We will irrigate. And like I said, we will worry about hypothermia later on at that point, but initially, right off the bat, we need to neutralize it. That needs to be the first thing that needs to be done. We do remove all clothing. You need to get all that off. The other thing that we run into is if we're not removing clothing, is we've had a couple instances of off gassing where the chemical is still lingering around, whether it's in the clothes or so forth. They start off gassing and we start feeling the secondary effects of it. So we do use quite a bit of PPE in the back, especially with your chemical burns and our initial neutralization of the chemical burn itself. Electrical injuries, like I said, are probably one of the most devastating burns that we see. And the reason I say that is the outside appearance of an electrical injury doesn't truly dictate what's going on with that patient. And the problem that we run into is we don't know the pathway it takes. You can kind of, if you find your contact points, if you find your entrance and exit type wounds, you can kind of guesstimate the pathway it took. But once again, it's more of a wait and treat type deal as opposed to one of these burns that we can see externally. The other problem that we run into with electrical burns is when we base calculations, we base it off TBSA, and your TBSA may be very small at this point. So we're truly kind of guesstimate at this point. A lot of times with electrical injuries, you'll get myoglobin in the urine, which could back up the kidneys. So we always want a higher urine output initially with electrical injuries, high voltage electrical injuries, anything over 1,000 volts. We start worrying about the myoglobin and so forth. So we'll keep an eye on that. We'll trend that either lab values, but once again, from a nursing standpoint, the best thing we can do is put a Foley catheter in this patient. We can see the quality of urine, the color, and so forth. If we start getting this darker colored urine, this cola colored urine, we will increase the fluids because we know the last thing we want to do is back the kidneys up, put them in acute renal failure at that point, and so forth. So with our electrical injuries, we always look for a higher urine output. And when I talk about fluid resuscitations, we'll talk about urine output and all this other stuff. As I talked about with the myoglobin, if you look at Don's picture, kind of that reddish color, but I've also seen a cola colored appearance, several different types of appearances that you'll get. As far as fluid resuscitation, I won't go into in great detail at this second. I'll wait for just a little bit. But when we talked about Parkland formulas and so forth, they always say 2 to 4 mLs per kilo. We tend to be on the 4 ml portion with electrical injury just because we don't want the kidneys to back up. And we will run a higher urine output over 24 to 36 hours just to make sure we're not going to back the kidneys up. The other thing that we run into with electrical injuries, depending on the pathway, we could be looking at if it goes across the chest, cardiac arrest, respiratory arrest, and so forth. So once again, if we can kind of see where the contact points are, we can kind of guesstimate, but a lot of it is just that we just don't know what it does till it starts affecting the patient or it starts showing. Some quick looks at electrical injuries. Once again, you can have that spattered appearance on the hand. If anyone truly wants to see the power of electricity, if you look at the bottom left-hand picture, that hand is basically in a fist, but if you look at the first finger, it's completely flipped on itself. So that truly is your blowout wound. That is your exit wound. That is electricity going through the body, blowing out. Now, when we talked about electricity, which I don't know if I've got, electricity has a hard time entering the body. So basically, it's a path of least resistance of what it takes. But once it does enter the body, it tends to follow like the nerve pathways and stuff like that it can easily get through. It has a tough time getting through skin and bones and so forth. So once it does get into the nerve pathways and so forth, we start looking at more muscle damage at that point. And when I talked about escharotomies and I talked about getting through the eschar, if we start losing pulses on these electrical injuries, they're going to have to do what they call fasciotomy at that point. It's going to be a little deeper incision. It's going to be actually through the fascia. They've got to allow that. They've got to open all that up, allow the muscle to breathe at that point, just kind of like compartment syndrome type issues. The other thing that we'll get with electricity is as it travels through the body, if it can't get up like through the shoulder, it will leave the body and then re-enter the body. So you'll have a flame type burn as well. If you look at the gentleman on the right, basically under the armpit, it left and came back in, caused a thermal burn at that point underneath the armpit. So you just never know what you're going to get with electrical, especially your high voltage type electrical injuries. When I talk to fasciotomies, if you looked at this picture, you can see the muscle and tissue damage right there. They are going to have to go in there, open that completely up, allow that muscle to breathe. But once again, something like that, once it gets that extensive, that deep, a lot of times they wind up either losing the extremity or losing function to that extremity. Pediatric considerations. This is where Dr. Kumar comes into play. We've made him a residential burn physician now. Just remember with pediatrics, a little larger surface area than adults. They're going to go hypothermic a lot quicker. The other thing is they tend to lose a lot of their temp or their heat through the top of their heads. So if you're going to wrap someone up with, especially with the younger population, make sure you wrap that head up as well, because that's where you're going to lose a lot of the heat. Thinner skin, as I talked about, same way with the elderly as well. So they're going to burn a lot deeper, a lot quicker. The other big thing to keep in consideration is their glycogen stores are smaller, so they're going to go hypoglycemic on us a lot quicker. So when I talk to outlying facilities as far as resuscitation type fluids and so forth, especially with the real little ones, you probably should add some dextrose to it as well to just make sure that you're not going to deplete that glycogen stores. The one thing I've learned kind of going back and forth between the pediatric intensive care and the burn unit is that kids will do well, but the minute they start going downhill, they drop like a rock. So we really have to be on our game, especially with the pediatric population, because they will kind of chug along and then all of a sudden just drop off that cliff. So really be on top of the game. With pediatric burns, we tend to see more scald burns, especially with the young children. And a lot of times I'm heating something up in the microwave, I leave it on the counter, I turn my back for a minute, the kid just reaches up out of curiosity or hungry and pulls that down on them. Top ramen is probably our number one scald burn with the pediatric population, just because of the temperature that it holds in. As they start to get a little older, you tend to see more fire flames type injuries, and this just is out of the curiosity of the adolescent doing things he sees his parents doing with lighters and so forth. Um, the other thing is with kids, they're just curious, and they get into a lot of things. They chew on a lot of things. They bite on things. We see a lot of during Christmas time, them chewing on the Christmas light cords and so forth. So curiosity gets the best of them at that point. Um, as far as the difference, like I said, between the children and the adults, just remember the surface area. So they're going to go hypovolemic on you, hypothermic, and so forth. As far as airways concerned, it takes a lot less swelling to occlude the airway or to hamper the airway than it would on adults and so forth. So when we're doing fluid resuscitation, a lot of that has to come in play, especially with the pediatric population. Unfortunately, we see a lot of abuse and neglect in the burn center, especially with the pediatric population. We are mandatory reporters. I always tell people if the story doesn't make sense, there's a reason, and the truth always tends to come out. But once again, the number one thing we should be concerned about is the patient care first, and then we'll worry about the rest of it. What I mean by abuse and neglect, we should never see definitive patterns on patients. If you look on the left, basically that was a child that was sat on a stove top. If a kid just naturally climbs up, gets on the stove, you should never have a definitive pattern. It should be more scattered out, as opposed to that same way with the picture on the right. You should never see that definitive iron pattern. If an iron fell on a kid, he's not just going to lay there and so forth. The big ones that we run into are more of the dipping type patterns, whether it's a punishment or something. If you look on the bottom right, you can definitely see that line of demarcation going across that thigh. We should never see that line of demarcation. If a kid's going to get into a hot tub, he is going to move around. He's going to splash. He's going to splatter. You're going to get more of those type burns than you're going to get as far as that line of demarcation. You'll see sparing behind the knees because the kid's first reaction once he gets in the hot water, if he's being held down in the hot water, is to collapse his knees. So you will get the sparing behind the knees, but you should never get that line of demarcation across the thighs or calves or wherever that line. Same way, if you look at the upper right hand corner, you see that line of demarcation. He kind of fooled us at first. If you pull his legs apart and all, you can't really tell, but the minute you push the legs together, you can see that definitive pattern. The butt cheeks being spared just because at that point that was what was in contact with the bottom of the tub. As far as treatment with burn care, I always say burn care is just like any other care that we're going to run into. The problem that we run into with burn care is that we're such a visual society and we treat what we see. And unfortunately, when we deal with burn patients, that's what we tend to focus in on. And from a burn standpoint, if it's just the burn, that patient is going to be pretty stable on you for a while. I can give you a lot of examples of 70-80% burns that will walk into the ER and they'll be alert and talking to them. Like I said, if it's just the burn, it's going to be stable. If there's something else going on, you've got to look beyond the burn, something else going on with that patient. But once again, burn care is just like any other care. It's ABC, what is our primary assessment telling us? Because he truly doesn't become your burn patient till you get to your secondary exam. You've got to get past all those primary surveys before he becomes a burn patient. What takes precedence over burns? Basically anything will take precedence. Airway obstruction, cardiac, any of that will take precedence over burns because that has to be corrected before we start dealing with burns. I always tell people out there, never feel like you're in this alone, especially if you're in the States or anything. We do a good job talking to outlying facilities and so forth. Here in Kansas, we have issues with weather, especially during the winter months, ice storms and so forth. So a lot of times they can't get that patient to us right away. So they become burn experts really quickly at that point. Your airway, if you just remember, if you just maximize airflow, if it's sitting them up, putting oxygen on it, or so forth, their O2 demands are going to increase over time, especially once we start fluid resuscitating them. If we can cut that off prior to that, our life's a lot better, whether that's a non-rebreather, nasal cannula. If you have any type of burn, facial burns or so forth, get them on some kind of oxygen because at some point they're going to swell. Um, when we talk about airway type injuries, when we talk about upper airway versus lower airway, the majority of your airway type injuries, especially with skull burns to the face or something like that, they're all going to be upper airway. They're going to be supraglottic. Your glottis has a good way of protecting your lower airway. I would say probably 99% of our burns that they're describing as inhalation type injuries are going to be supraglottic type injuries. Those are very easy to treat. It's your subglottics. It's a patient that was unresponsive in the house fire that body relaxed, now it allowed everything to get down. Those are your subglottics. Those are the ones that increase mortality just because there's not a lot we can do with these patients once it gets down to the lower airway. Very good with tracheal suctioning and so forth, but once again, nature has to take its course with your subglottic type injuries. Ever in question, I always tell people, intubate that patient, get a tube down them, get a secured airway. If you look in the picture to your right, anhydrous ammonia spray to the face. I would much rather us get a tube down on the top, than wait until it gets to the bottom picture where it's all swollen and your cronin and everything is now shrunken. Pediatric considerations, remember their airway is going to obstruct a lot easier. Like I said, just avoid hyperextension if you go to intubate these patients, a little more lateral at that point. Weaker accessory muscles, so they're going to go down quicker than adults would be. We always say use the cuff tube with the pediatric population. I don't think we even use uncuffed tubes nowadays. But once again, we've got to secure it because that kid will chew through your medications, chew through sedation and so forth. So we really have to be on top of our game as far as tube securement because that tube will get dislodged pretty quickly. When I talked about intubation, just remember that's a clinical call. We never fault anyone for intubating a patient just because, like I said, I'd much rather see that patient come in intubated and us reverse them and then get them extubated than waiting too long before they get intubated. Case in point, if you look at this gentleman right here, he was intubated on admission 24 hours post, same patient. That's the amount of swelling that you're going to run into 24, 36 hours. And that's all going to be the amount of fluid that we're putting on them. And if we didn't have a secured tube at that point, we would have never gotten one down. We talked about the airway. We're going to talk about breathing now. Just assess your rate depth, just like you normally would do. Is there any adventitious breath sounds? Are the patients struggling at this point? When I talked about chest wall excursion and so forth, is it rigid? Are they able to still get that chest wall excursion, or is there something that needs to be done prior to moving on at this point? And like I said, escharotomies on your thermal inflames, what we want to do across the chest, whether it's in your rectangle pattern, your tic-tac-toe pattern, or so forth. If you can't get that good tidal volume, if you're having a hard time bagging and so forth, kind of keep that in the back of your mind. It could be that full thickness burn, not allowing that expansion at that point. And when I talked about chest escharotomies, here's a good picture of it. We tend to make one more final cut down lower, so it tends to be more of a rectangle pattern or a tic-tac-toe pattern as opposed to just that H pattern right that you see in there. Once you get your breathing under control, whether you intubate them or so forth, move on to your circulation. I always kind of chuckle when it says provide CPR if indicated. You probably should have done that to get go. But if you wait till this point, this is the time that we would do it. The big thing to remember with big burns is they're going to be a little hypotensive, but they're going to be tachycardic. If they're not tachycardic, an ominous sign that something else is going on at that point. You want that higher heart rate to keep up with everything that's going on. So if you put them on a monitor and all of a sudden your heart rate 60s or 70s, not a good sign. Assess circumferential extremity burns. If you do nothing else, O2 set at the end of the extremity, check refills or so forth, but just keep an eye on that because as it body starts to swell, and especially with your full thickness burns, it's not going to allow for it to swell. So keep an eye on that. Like I said, we have time 4 to 6 hours once you lose pulse before you lose the extremity and so forth. But one thing to keep in the back of the mind. Also, during this time, we placed 2 large bore IVs. I know this kind of sounds like trauma. This is about the only time that trauma and burn will go hand in hand. We kind of split off after this point, whether it's through good skin, burn skin. The issue that we run into with burn skin is it's really hard to secure the site. We have a big residency program here, so we have a lot of physicians that will put in central lines and all, which work well for us. But in outlying facilities, IOs work well, IVs work well. The problem that we run into with peripheral sites is if we go over burn skin, it's going to be hard to secure. The other issue we run into is if you don't keep an eye on it and the extremity starts to swell, you're going to lose your IV site pretty quickly as well. Our fluid choice is lactated ringers, but I always tell people just to go with whatever fluid their protocols call for. To this day, we still say lactated ringers just because of the lactate in there. We always feel that it can kind of help keep fluid in the vascular system as opposed to leaking out. But as current studies have shown that no matter what we do for the first 24 to 36 hours, we can't control that seepage of fluid. So we have to keep up with it. So when I talk about fluid resuscitation, that is what our goal is, to keep up with what is leaking out of this patient, the plasma and so forth that are going out extracellular as opposed to endovascular. Early fluid resuscitation, this is what I try to drive home to everyone. This is our recommendations as far as fluid resuscitation and how fast we run it. Now, when we talk about fluid resuscitation, we do not resuscitate anything less than 20% TBSA. We feel anything less than 20% can either orally resuscitate themselves, or we can just run a set rate and keep up with what they're losing. Anything greater than 20%, we do a fluid resuscitation. With the pediatric population, when I talked about they're going to lose more than adults would lose, we drop it down to about 15%. We've even dropped it down to about 12% at times just to keep up with it. But when we talk about fluid resuscitation, we always go major burn, which is 20% on adult, 15% on child. We don't bolus or diurese the patient because we want to see what they're naturally putting out. We don't want to artificially create urine. When I talked about fluids, when you do your C's, you start your fluid resuscitation. Like I said, nothing that's done pre-hospital or first hospital should be based off of TBSA. What we're saying is 5 and less, 125 an hour, 6 to 12, 250, and greater than 13 years old, 500 an hour. Set rate, you don't have to adjust it up or down. So there's no figuring out TBSAs. You can kind of look at it and say, yeah, this is greater than 20%. This is something that we probably should do. From an outline facility, pre-hospital flight type situations, they don't put Foley catheters in, so it's very hard to do a fluid resuscitation without your second part. So like I said, we go out and we say, this is a set rate, this is our recommendations till they get to us. We will even in the back, if fluids haven't been started, or if this patient just comes in from EMS right down the street, this is what we'll set it off. We'll set our fluid initiation at before we figure out TBSAs. Your disabilities, once again, check your level of consciousness. If his level of consciousness is starting to decrease, start looking at other signs, hypoxia, and so forth. Whether you do ABFU, Glasgow Coma score, or so forth. Once you get to your E's, this is your environment and exposed. Basically, this is where you open them up. You say, okay, I've got a burn, but I'm still not figuring out TBSA. When I talked about hypothermia, get them covered back up. Just expose them, look for anything life-threatening, nothing life-threatening, cover them right back up till you get to your secondary exam. Your secondary exam consists of adjunct treatments, your laboratory, and so forth. I know a lot of people do labs when they put their initial IV sites in, but get a good baseline CBC, renal, and so forth, because fluid resuscitation will tend to dilute out a lot of those lab values. So if you get a good baseline, a good weight, and so forth, head to toe assessment. When you do your head to toe, this is when you figure out your TBSA. If you want to figure out your TBSA, good starting point. I'm starting in my head, work your way down. Whether you do Rules 9, London Browder, and so forth. Pain and anxiety, kind of hard to talk about that subject because pain and anxiety is a big issue with burn. Really hard to control burn patients' pain. We do the best we can. Like I said, we try to do co-pharmaceutical type treatments. whether it's Dilaudid, fentanyl, whatever we're using, and Ativan, we've got to give one or the other. You've got to control both, because if you don't control both, one will override the other and so forth. The big thing with IV pain meds, always make sure we give IV. We never give IM, because on the initial phase, your third space and everything. So anything IM, just going to go back out system. So you're not going to really touch them with IM type medications. We have tried some with intranasal. Doesn't work as good as IV, but once again, that is a choice you have, that you can do intranasal as well. As far as fluid resuscitation, this is kind of going to wrap this talk off. But we used to use Parkland formula for years, and Parkland formula was 2 to 4 mLs per kilo times percent. We've gone more to this consensus formula, and basically it just breaks it down. Your adult thermal and chemical, 2 mLs per kilo times percent. Your pediatric is 3 mLs per kilo times percent. Once again, if you are going to do the very little ones, remember they're glycogen stores. So if you add D5, could be D5LR for your resuscitation, D5NS, whatever you have. And then high voltage electrical injuries, anything greater than 1,000 volts, we always want to increase the fluids, because we want to flush out the kidneys initially right off the bat. So we start that off at 4 mLs per kilo. As far as urine output, if you're gonna do a true fluid resuscitation, you not only you need to know what's going in, but you need to know what's going out. This is what dictates whether we're keeping up with kidney function and so forth. That's, like I said, we don't give diuretics because we don't want to falsify these numbers. So what we're looking for every hour with the adult is around 30 to 50 mLs of urine an hour. Children less than 30 kilos, 1 ml per kilo. Electrical injuries, we want that urine output to be a little higher, 75 to 100 of urine output. So just real quick thing, 50-year-old, 40%, rise 2 hours post-burn. If you look at it, thermal burn, 2 mLs times the weight times percentage, that's 6,000 total over 24 hours. So that number gives you what they should get in 24 hours. You divide that in half, and then you give that over the first 8 hours. So it winds up being about 500, which is what we talked about earlier when I said set rates. If we don't get the 20 to 30 mLs per hour, or 30 to 50, we increase fluids. If we get greater than 50, we would decrease it. Same way with your pediatric and your electrical type injuries. This is kind of our protocol here, but basically it breaks down the same way. As this is what we'll start it at. Every hour we're kind of looking at urine output. The one thing that we do keep in the back of our mind is bladder pressure. As we know, the more fluid we get introduced to a patient, we start looking at compartment syndromes, bladder pressures, and so forth. So we keep an eye on that as well. I always tell people, any questions, concerns about burns, there is an ABA referral criteria, and it's written so vague that any burn that anyone would deal with would fall into a category. Doesn't necessarily mean that we need to see every burn that comes here. A lot of things can be talked about over the phone. But once again, if you are not comfortable with burn, we do have this ABA referral criteria. I know I kind of went over just a little bit. I apologize for that.